isn't it?
Yes, sir.
So you see CSME and then order a lipid profile, rather than see a lipid profile and then ask for an OCT. That's what sir is also mentioning.
Okay, sir.
Okay, thank you.
Thank you.
Okay, sir.
The next presentation is by Dr. Pooja Maitra, establishing an algorithm to decode the phenotype of fleck retinopathy.
Can I have my slides, please?
Pin number.
583.
Yes.
Can I have my slides? Good morning, everyone. Coming to the topic of establishing an algorithm to decode the phenotype of fleck retinopathy. So what is fleck retinopathy? It's a group of disorders characterized by multiple yellow-white retinal lesions of various sizes, configuration, and distribution with various amounts of retinal dysfunction. So the aim of the study was to decrease the dependence on investigations for diagnosis of such cases, which can be done if phenotypic clues are picked up. So it was a prospective study of previous undiagnosed cases of fleck retinopathy. Step 1 was grouping of the patient based on the symptoms and the best corrected visual acuity. This was done by the optometrist. Step 2 was clinical examination and investigation, which included spectral domain OCT, fundus photography, and autofluorescence, and full field ERG. Step 3 was regrouping of the patient by 2 VR practitioners, and step 4 was diagnosis and assessment. So we looked at the phenotype of 60 eyes of 30 patients who had a mean age of presentation between 4 and 48 years. The history of consanguinity was present in 60% patients. So now the initial group was group A, B, C, D, E, which was done by the optometrist, but finally after regrouping, we had group 1, 2, 3, 4, 5, 6. So group 1 was 5 patients from group A who were diagnosed to have benign fleck retinopathy. Group 2 was 4 patients from the group B who were diagnosed to have fundus albipunctatus and enhanced Escone syndrome. Group 3 was 9 patients from group C who were diagnosed to have fundus punctata albicans and fundus flavimaculatus. Group 4 was from the group D, diagnosed to have severe early onset cone rod dystrophy. Now, 1 patient from group B and 2 patients of group C were clubbed into group 5, which was the crystalline deposits, and group 6 was the undetermined category. Now, regrouping of the patient from the optometrist level to the doctor level happened in 20% of the patients. Now, this is a complex results table, which I will simplify further. So in group 1, the flecks were bilaterally symmetrical, and they were yellow-white lesions extending from the parafoveal region up to the periphery, where they were actually more confluent and appeared to be coalescing. So this was consistent with the diagnosis of benign fleck retinopathy. In group 2, there were actually 2 patterns. The first one had an electronegative B wave on ERG. So these patients had a more packed mid-peripheral flex, and this was consistent with the diagnosis of CSNB, fundus albipunctatus. In the same group, 1 patient had a ERG finding which was consistent with the diagnosis of enhanced Escone syndrome. Now, this patient had yellow-white hyper-autofluorescent dots which were within the arcades. Now, in group 3, again, we had 2 patterns. Nyctalopia was the presenting symptom in 3 patients, and the flecks in these patients were very indistinct, and it was associated with arteriolar attenuation. The autofluorescent had a very good Robson-Holder ring sign, these were the patients who we diagnosed as fundus punctata albicans. In the same group, 6 patients did not have the history of night blindness, and they had these typical pixiform flecks which were located within the arcades, and it was associated with some amount of foveal atrophy, where we diagnosed the patients at fundus flavimaculatus. Now, in this group, another patient had this peripapillary RPE sparing, which was seen in autofluorescence, which is a finding typical of ABCA4 mutation. So for want of time, I'll just skip this, and I will go on to the undetermined category. So this was a 12-year-old girl who came with night blindness, 6/6 vision, and her ERG were almost normal, and she is under treatment for multiple systemic issues. She is currently under evaluation for vitamin A deficiency. Coming to the discussion, so fundus photograph is more than just for documentation. These images can be reviewed for a detailed phenotypic assessment at a later date. Autofluorescence is a great tool because it enhances the characteristic of the flecks and acts as a functional map and gives some genetic insights as well. Now ERG, although an extremely important investigation, but may not be required in all cases unless you have atypical features. So from this we came to this algorithm where we propose that in good visual acuity, patients with night blindness require ERG to come to a diagnosis. In patients who have moderate visual loss, OCT and autofluorescence are extremely important, and ERG can be an adjunct when you don't get any clue from your first line. In patients with poor vision and crystalline deposits, the phenotype itself gives you enough clues, so dependence on investigation is not required. And again, in the undetermined group, other than ERG, maybe systemic evaluation and genetic testing plays an important part. Now, when dealing with children, we have the problem of unreliable history and maybe even evolving phenotype, which we do not understand right now at that point. But what is important to remember is that many of these babies who are photophobic will have better compliance, you can take fundus images much easier than examine with your IO light. So just to conclude that although genetic insights have changed the way these entities are currently being classified, but genetic testing is out of reach for a lot of people in our population. Phenotypic assessment is very important with all the tools that you have in your clinic, and the phenotypic study has helped us form this algorithm where with minimal possible investigation we can prognosticate, diagnose, and even give a risk assessment to the siblings and offspring. Thank you.
I just want to add one to the algorithm. In that group 2 where you have the fundus flavomaculatus, you can have a prolonged dark adaptation. Post prolonged 2-hour dark adaptation, the ERG improves further. So yes, that is one of the diagnostic criteria.
Yes, sir.
Yeah.
Yes, sir.
Thank you. I think it was very nice because of positive time. But just to say that all this data, if you put in the AI, it might help us in the long run.